Hi. Post-lunch sessions are always a little. Am I audible now? Thank you so much. Post-lunch sessions are always a little difficult, right? And when we talk about Equitable AI, we have been talking about AI and amazing technologies all day long. When we are talking about when we are talking about how some of these technologies are actually impacting us, not just us, but all of us. Sometimes I wonder, a lot of these technologies are made by doctors. Less than 2% individuals actually work in the healthcare industry globally. Do we really have a look at the rest of the 98%? People who genuinely need some of these systems, people who are the beneficiaries of these, right? And today we will dive a little bit into what's going on, what are the strategies for actually reaching the rest of these 98% that exist, who are the beneficiaries of all the technologies that we are building, all the solutions that we are building. And we are talking about impact across the board, including rural impact as well, which is again more than 66% of the world population. So, this is WHO data, published data. I'm sure most of you know about it, that just 33% of the global population actually have access to health coverage. And this is not universal coverage. I mean, it says full, but it genuinely isn't. We are not talking about large-scale solutions in prevention. We are just talking about overall 33% people actually having some level of access to advanced health therapies. Now, what happens to the rest of the 67%? 67% of the population today faces significant gaps. And today we are going to talk about some of those gaps and what we are trying to do to solve them. So, what has been the demand for AI from the global public health industry? And I've spent about 2 decades into that. So we are trying to get almost 4.5 billion people access again. We are trying to get 100 million people who are forced into poverty every year because of emergency health crisis to be avoided from it. And we are trying to get almost 1 billion people who face financial hardships to be avoided for. And how do we do all of this? We do all of this through prevention. I mean, we are sitting in a hospital today, in a tertiary quaternary care referral center, which is one of the best in class in the country. But what's the real goal of healthcare? Can one of you just give me an answer? What is the goal of healthcare? Just anyone, just shoot an answer. Goal of healthcare is health. Goal of healthcare is avoiding the need of care. I mean, that is something that we need to fundamentally understand, that the goal of the entire global healthcare system is to disappear, not to succeed in solving diseases, but to make sure that we are not needed anymore. I mean, tough to say because all of us are doctors after all, but that is truly the goal of healthcare. And there are 3 main crises that today we face, right? I mean, we call it the 3A crisis. It is the problem of affordability. We all know that, just about 10% people actually have access to affordable healthcare. People spend, almost 1 billion people spend more than 10% of their income on healthcare expenses. You have almost 200 billion in annual funding gap when we are looking at universal health coverage. And what do these numbers actually mean? It means that when a ton of people need it, more than 87% people need it, they cannot afford healthcare. And this is actually when they need it. We are not even talking about the time when people are actually not aware that they need it. So that is when the accessibility and accuracy problem come into play. Now, accuracy is such a big problem that it generally gives me a nightmare, because we don't know what we don't know. And that's the problem that any tech tool also suffers. Most of the data that we have today is built on best estimation of information, best estimation in each clinical decision that we take. Now, are these always correct? We don't know. We have, as earlier panels have also spoken, there are problems within healthcare systems that are created. Some of the NCDs have been induced. And of course, AMR is a problem of behavioral shift that was created out of a solution. And today, it's a stuff of nightmares, unfortunately. So accuracy of care is certainly a massive problem, and so is accessibility. So we have the problem of affordability, we have the problem of accessibility which is actual distance, physical distance to hospitals. We live in large city right now, but when we go to the rural spaces, we go to Rwanda, we go to Gabon, we go to places in Cambodia, we go to northern Thailand, there are not enough doctors, there are not enough hospitals. And it's not even about doctors, there aren't enough caregivers or platforms that are accessible, and that's a given fact. Now, what are we really doing? If we forget about the terminologies, what really does this problem look like? This happened twice in Rangpura, in the same hospital, mind you, in 2019 and 2024, where the entire hospital's cardiology department, the CCU, were overrun by cockroaches so badly in Bangladesh that they had to shut down the CCU for about a month to fumigate. This is what we are talking about when we are talking about problems. This is not a rural center, this is actually an urban center where this has happened. Sub-Saharan maternal deaths have actually tapered down on the decline. Today, when we look at Sub-Saharan region, the maternal mortality rate started going down in the 90s, started going further down in the 2010s. Today, they have tapered. So, what is the problem? The problem is the same: affordability, accessibility, accuracy. Because of these problems, the journey times are long. Roadways, the basic problem of roadways in Africa is resulting in people reaching almost 3 to 5 hours later to a destination that could have reached with normal roads. And apart from Rwanda, every other country, unfortunately, Chad is one of the worst, but every other country has shown actual taper down on the reduction in maternal mortality. One of the clearest markers of success, right? I mean, all of us started, when we started studying, we started about maternal mortality, and we knew कि अगर हमने maternal mortality सुधार लिया तो we are on a right track. And if that is tapering, then that's a given problem. Malaria crisis. 3 countries and almost half the deaths in the world, right? Nigeria, DRC, Ethiopia. 3 countries, one avoidable disease, simple solutions both in prevention as well as in cure, and yet this is the death rate that we are still facing every year, and this is a seasonal change which we can very well avoid. We have enough solutions proven across several different geographies, and yet access, affordability and accuracy of care delivery is not happening, definitely not in the preventive case. Also, we all know, and we are going through it, we are going through a massive climate health emergency at this point. We have been talking about One Health for a few years now. We know that animal health, climate health, and human health care is all one thing, is all one convoluted and interconnected mesh, which we have to solve all together, not one at a time. Temperature rise, hotspot overlays, actual deaths caused because of increasing temperature. All of this is real, and it's not just in India. It's also happening in the APAC region. It's happening across the equatorial belt. It's happening in Northern Africa. It's happening in LATAM, in Panama's, in Trinidad, in so many other places where, because of that, humidity crisis is rising, vector-borne diseases are more, and hotspot overlays are now conducting into proper climate crisis changes, right? AMR, of course, again, something that most doctors who know about it face a little bit of fear every time they think about. We know that a superbug can very well be a reality, and a bacterial superbug, we don't really have an answer to. There hasn't been a new strain of antibiotics really invented in the last, 45 years, right? We are just about repackaging and oxidizing the same thing. One of the areas where there are problems that we are facing. Now, is it all about the problems? No. Are we doing some things right? We are, we certainly are, and we are on the route to slowly and steadily use technology to solve some of these problems. And they are also the same thing. We are solving affordability. How? We are solving affordability through digital scale. Scale in, and structured care delivery and access to everyone is the only solution that we can see in the foreseeable future that can actually solve both cost as well as affordability, right? When we take everyone into the fold, we are almost touching 9 billion people, right, at this stage. So when we take 9 billion people, economies of scale actually play out, market forces play out, and that is what digital scaling is affording us to do. Today, even if there is no doctor, even if there is no pharmacy, there is still a digital supply chain that's acting out in so many parts of the world. Today, when we work in places like Gabon and we work in places like, for that matter, Ethiopia, we actually see some of these supply chains playing out beautifully well, right? Second is remote reach. So one is scale, second is, as I mentioned, is remote reach. And third is slowly and steadily, while we are personalizing care at the highest level, we are also structuring care and making sure that there is some level of uniformity in access and care delivery. We are doing that through digital tools, through making sure that there is not just a fragmented structure of data input, but as we have been talking since morning, we now actually have data frameworks coming from multiple different sources, multiple different countries, and what that is doing is democratizing. That is democratizing the tools that we are creating. And because of that democratization, what is happening is that now we actually have some level of standardization in care delivery where earlier there was nothing. Right? We have to understand the delta that we are creating. This is where people have zero access, and now they have not just information, they have some level of accessibility, and because it's so dirt cheap, it is also affordable. So affordability solutions are in action. Like ABDM is one solution that is fundamentally shifting the way we are looking at PHR, public health records. Now we are not just owning our own records, but as we mentioned earlier in other sessions as well, we are fundamentally changing our relationship to our health data and data in general. Now we are creating a framework where we own our entire care plan, right? And not just a care plan. I mean, technically in India, that's not even a term. What we are doing is, wherever we have a touch point with health systems and people, I think we are still confused what ABDM is about. It's amazing, and what it's doing is whenever you touch any healthcare ecosystem, be it a pharmacy, be it a hospital, be it a doctor, be it a diagnostic center, all of the data actually comes and integrates into the same location. And that is your wallet, that is your data, that's your PHR. And that is what you're owning, and what that is doing is creating vertical frameworks that is fundamentally changing the way we are talking about. And this ABDM is now changing PMJ, right? PMJ was actually a social welfare network, which was an insurance system covering 87% of the bottom layer of the population. I'm sorry, I will go slightly over if that's okay. So the point is that that is what fundamentally we are changing, a payment structure which is anchored on PHR systems. Accessibility, right? Today, the Common Health and Wellness Worker Network in Rwanda is one of the biggest, of course, after India, because we have fundamentally shown the world how the AAA network, the Asha NM Ankanwadi network should operate, and we actually cannot celebrate that 50-year-old effort enough, that we have made a network of 1.8 million frontline workers who go home to home. Almost all women in this network go home to home and conduct all kinds of health services, from our entire polio vaccination system to the fact that the first wave did not affect India as badly as it should have. And the entire vaccination drive and so many other things are completely anchored on this one system. We have done fundamentally well. Rwanda actually adopted from our system. We had actual public health workers from Rwanda visit us in the late 1990s and study AAA systems, replicate that, and now almost 15,000 villages have complete healthcare because of the CHW network. Also, there is accuracy solutions that are being built. Dubai is one good and very interesting use case. considering that it's a small diaspora of 3 million people. Today, AI health assistants are being actively deployed for clinical support, for efficiency and scale in an extremely varied population. And here is where diagnostics and care delivery systems without consideration of cost is playing out very beautifully. So what are we talking about? We are talking about tech, deep tech, and the strategy systems that are fundamentally shifting the way now healthcare systems should play out. So there is the first layer, the infrastructure layer that was built out, we all know about. I know I'm a little short of time, so I'm going to rush a little. Then we have data and AI systems, the health record systems, the predictive systems that we just spoke about. Then we have the applications of that. That's extremely important. We have telemedicine, which is multiplying the time a doctor can possibly spend on a patient and the impact. Mobile health systems, digital therapeutics, new testing technologies. And now we have the governance layer, which governments across the board are playing out, which is interoperability standards, the FHIR protocol, the HL7, which is almost universally accepted in India today and almost all health systems, but we actually are building on top of it. So we have structured these 4 layers well. We just have to keep on applying it across not just the tertiary care and quaternary care ecosystem, but downwards towards the primary and secondary as well. So the real solution, as I spoke about, or rather I spoke slightly sooner about, is the Asha revolution which happened in India. Today, that is increasing access to almost 85% of the country. The thing is, these are the single point of contact for healthcare for 85%. What that is doing, that is increasing scale, that's increasing access, and that is solving for affordability because of scale. We have market forces playing out because today we are able to create a network of access. Same thing, Rwanda has a very good tech story. So Rwanda and Kenya actually, Zipline is a company which now is a not-for-profit, I believe. They have been delivering blood and emergency health solutions to almost 12 countries in Africa, and emergency management of care across COVID was done by them. They are not just doing it across Africa, they are doing it across several different geographies as well. So, and of course, the Japan's climate health AI system, which is an early warning system that's doing fabulous work in flood and earthquake prevention and solutions around preventing damage of life during that, is predicting both health and earthquake, heat, floods as well as earthquake in this solution. So if we could redefine human life itself today we are talking about human life from 2 things. One is prevention and second is the potential we are building about. I'm going to go very fast now. We are talking about 2 moonshots. We are talking about longevity. We are talking about what the world is going to look like when 60 becomes a new 100, right? Or rather 100 becomes a new 60. So what is health evolution? We are talking about biotech. We are talking about crazy innovations in biohacking and anti-aging, which is fundamentally changing the way human life is going to age. But along with that, we also need to look at what aging is going to look like for the masses. We are going to have an aging population that's going to be paid for by the taxes that are much smaller than the population is generating. Sorry, I'll just finish this off fast. So, and we of course have the fertility revolution. That's a problem and a solution both happening all at the same time. The reduction in fertility rates, how that is impacting our younger population, as well as what we are doing to solve for that. So, and we have the AI companion. Digital twin, the way we are structuring it across the entire value chain is fundamentally changing the way we are going to access data, and PHR is the first point of entry into that look that we are creating. So equitable health coverage is within reach, but we have to think differently. We have to think about prevention and we have to think global. I think that is the biggest takeaway from this entire value chain. We have been delivering healthcare at root, and I think that is where we need to start. We need to start with grassroots innovations. And this is a question I want to leave you all with. Are we building for the love of science and only for the people who can afford, or are we building for everyone? Because the day we start doing the latter is when healthcare system will succeed. Thank you so much.